Welcome friends, welcome colleagues, welcome students on MuniMeterHealth, your source of learning cardiology and about human heart. So this is Dr. Jaitly. Welcome again on MuniMeterHealth, your favorite source of learning. Briefly, we're going to be talking about the treatment algorithms for heart failure that are available. So let's consider some very important scenarios which are very commonly seen. So again, it's very hard to sort of complete everything in one video, but I'll try to point out some very important scenarios. So first scenario, for instance, is where you have, say, New York Heart Association classification of, say, 2 to 4. More or less. Now you have these patients who have a creatinine clearance, say, of more than 30, and their potassium is less than 5. So all these patients can certainly qualify for aldosterone antagonists. Remember that. So this is a very, very important drug which is very old, and unfortunately it had been forgotten for decades. It's coming back. So there's a resurgence in the past 10-15 years. Aldosterone antagonists like spironolactone can be prescribed to these patients. And now this is obviously in addition to patients who are already on ACE inhibitors. They may be on ARBs if they are not on ACE, and of course they're on beta blockers. Sometimes these patients can be on diuretics depending upon their volume status, but diuretics are only as when needed, so we call it a PRN. Like if they're volume congested in the lungs or they have ankle edema, one can use diuretics. So that's one scenario I think it's very commonly needed to be sort of ascertained. Another good one is, which I normally say, is the African American population. Remember that. African American population, they are very, very specific in that they respond very well to a combination, I call it a combo, isodil hydralazine. Now these patients respond very well only in the setting where they have class 2 or class 3. Remember, you can't use them in class 1 or class 4, but only in class 2 or 3 of the New York Heart Association. Isodil and hydralazine can be added to this combination here. So that's only in the black population or African American population. Another important entity is, again, we are talking about class 2 and class 3 in these settings where patients have had an MI, and the post-MI rather 6 weeks now, and their life expectancy is more than 1 year. So survival pattern is, so these are the two caveats, and their EF is about 35% or less. So they are less than 35%. So these patients qualify for an ICD placement. However, if the QRS in these individuals is more than 150 milliseconds, just so that you know, if it's more than 150 milliseconds, that means there's a wide QRS, because normally the QRS will be something like this in this setting, whereas in the patients who have a prolonged QRS, they'll have a prolonged QRS. So these are the patients who would qualify for a CRT or cardiac resynchronization therapy. This is intracardiac defibrillator. Okay, so intracardiac defibrillator, and this is a CRT. So CRT is normally required when the QRS is 150 milliseconds or above, because then you can actually resynchronize the ventricles better. Now, this is what I mean when I show the resynchronization. Here's your heart. Here, look at the right side of the panel. I'm drawing the heart, and when I draw the heart, what happens is, this being your LV and this being your RV, if you pass, say, using a different color code here, this is where the resynchronization will occur. So one tip of the pacemaker wire is placed in here, another goes via the coronary sinus and lodges into the other side of the left ventricle, if you will. And then, of course, there is another which is a coil that's stimulating somewhere around here. So essentially what you have is an ICD placement, plus you have a coronary sinus tracking on the other side of the septum, that means the left ventricular side. So as a result, we know that the left ventricle contracts earlier than the right ventricle. However, when you have a QRS prolongation like in a left bundle branch, obviously you have a left bundle branch and the QRS is more than 150 milliseconds, 0.15 second if you will, those patients, they have a left bundle which is slower because it's a left bundle blocked, right? So now you have impulses traversing here faster, so you're resynchronizing the left ventricle and the right ventricle in a more physiological way. And the prolongation of survival is very clearly seen in these patients, because these patients definitely have shown a great deal of survival pattern improvement when you give them a CRT over an ICD. So that's a very, very important scenario. Coming back to another scenario which I commonly use here for an example is where the beta blockers have been maximized in patients. Remember that sometimes you can maximize only to a level, but the heart rate is still more than 70. So what do you do in those patients? So those patients really qualify with a new drug. It's called ivabradine. However, no prolongation of survival is seen with ivabradine, but it certainly is very symptom controlling drug, because these patients who tend to exercise while on fully maximized beta blockers, they get compromised because the heart rate starts jumping up to 90 or 100. So ivabradine works. It's an I-channel drug, and that is now utilized to control the heart rate even better. So remember, these patients obviously cannot be in AF, so they have to be in sinus rhythm. All these patients are in sinus rhythm. Likewise, patients who have a QRS prolongation, they also have to be in sinus rhythm here. So having ascertained these various groups, we can also move on to define a very important group where you have class 2 and a class 3 patients. Their EF is obviously lower, but not lower than 40. EF is, say, about 40%. These patients, and they have a good blood pressure control. They have creatinine clearance normal, and the blood pressure is okay, and the potassium is less than 5. So these are some of the criteria to use a drug called ARNI. It's a very important group of drug, a combination drug rather. It's an angiotensin receptor neprilysin inhibitor. So it has an angiotensin receptor like in ARB, which could be which is actually an ARB like an enalapril, and then you have sacubitril. So you have enalapril, you have valsartan and what you may call a sacubitril combination. So the valsartan is there, and then you have sacubitril as the combination, sacubitril. So this is the starting dose here is 49 to 51, and then BID, and then it can be increased if necessary, and we can discuss all those at a later time. But just so that you know, these are very important scenarios which I wanted to just go over in a heart failure setting, where we commonly encounter like patients who are already on ACE, ARBs, and beta blockers. What do? Diuretics. Now these patients, you want to prolong the survival, add aldosterone. Aldosterone would be a good drug, provided the potassium is less than 5. African American population use isodil and hydralazine in addition to the rest of the regimen already present, but make sure they are in class 2 and 3. Class 2 and 3, EF less than 35, and they've had an MI, and the caveat is the survival pattern is estimated, again estimated or assessed, or is predicted is more than a year. Those patients can qualify for an ICD placement, or if the QRS is prolonged, like a left bundle branch where QRS is more than 150 milliseconds, you can give a CRT. Another group of patients which I just discussed, where it's reasonable to start a new drug. Now this is a brand new drug, ivabradine, and that ivabradine may be used only in a setting where somebody's beta blockers are maximized, but the heart rate is still more than 70. And lastly, but not the least, is the group where ARNI group of drugs can be used, and these are very, very important new drugs. Only in the past couple of years they've come around, but here the ejection fraction is less than 40% for those patients. Patients are either on ACE, ARBs, or beta blockers, and or combination, and those patients, their blood pressure is okay and they can tolerate the ARNI group of drugs. Creatinine clearance is good, and potassium is less than 5. So remember, when you're starting an ARNI, you have to discontinue two things: ACE, because you don't need that, because you already have a valsartan, and obviously you'll discontinue your ARB here as well. So very, very important, please guys, make sure you discontinue the ACE and ARBs, wait about for 24 to 48 hours preferably, and then start the ARNI. So it's a switch is switch is a little tricky, but you have to explain the patient and do it very carefully. Alrighty. So this was a quick nutshell on the treatment algorithms with some interesting scenarios. So we have presented about 5 or 6 scenarios here for you in a setting of heart failure. All right, and hope you enjoyed it. So continue watching MuniMeter Health, your favorite source of learning cardiology and